Hi everyone. I'm very happy that so many of you stayed from the previous keynote speech, and I'm sure that you're very interested in our topic, which is going to be about trauma and trauma therapies, and specifically MDMA-assisted psychotherapy. So, already very enthusiastic. Very good. Okay, so let me introduce our panelists today. So first off, here we have Júlia Richter, who is currently the director of Trauma Center here at Budapest. She is going to be our basically guide through what trauma is. If you know Hungarian, you can also check out her podcast on the Trauma Center's blog. Now, yes, a little bit of applause would be okay as well. Yes, very good. Our second speaker is Dr. Móró Levente, who is specifically researching MDMA-assisted therapies. He has been in talks about this for the past 20 years, as far as I know, 15, something like that. So he is very well aware of everything that's involved about this topic, from policy through actual therapies. And lastly, our keynote speaker, yes, for Levi as well, a little bit of applause, sorry. And lastly, our keynote speaker, Olivia Remes, is also joining us, who is a mental health researcher at University of Cambridge. So here we are. Thank you. Right. So first off, my question is going to be for Júlia about what trauma is. So we've talked about this previously, that it's not an easy topic to summarize in a couple of minutes, but what I asked her to prepare is a little bit of an introduction of what trauma is, what is specifically PTSD, which we're going to be talking about a lot today, and what are some therapies that are specific to PTSD.
Okay, thank you. It's so nice to be here. My name is Júlia Richter. I'm the clinical director of Trauma Center, and I'm a clinical psychologist. And can you hear me well? Yeah? Okay. So I've been working with refugees and trauma for the last 10 years or so. And seen catastrophes and the aftermath of these situations. So when I ask what is trauma, for me it's, and also for my passion, it's something that is really overwhelming, it's threatening, it's something that threatens your life. It's an event that overwhelms your central nervous system as well, and it alters the way of recalling and processing the memory. As Bessel van der Kolk, a very famous trauma researcher, says, it's also the imprint of the fear and the terror of that event that is here with you in the here and now. It's not about the memory of what happened then. It's what is here with you. And so when we talk about trauma, it's not just an unpleasant event that happened to us. It's something really major. And we might just witness this or suffer it, but the threat of life and feelings of helplessness is very often there in these situations. PTSD is post-traumatic stress disorder, something that we're going to talk about today. And it might be a reaction to a traumatic event. So not everyone who suffers through a traumatic event develops PTSD, which is good news, right? So just surviving something that was traumatic or was possibly traumatic doesn't have to lead to PTSD, but for some people it does. PTSD is something that it's a disorder when you're kind of, your body and your mind is stuck in this survival mode. The traumatic event triggers this fight, flight, or freeze reaction that probably many of you might have heard of. And someone who has PTSD is stuck in this mode of always wanting to survive, basically. So something that helped them at that time, it doesn't help them in their everyday life. In terms of symptoms, it alters or vigilance. So some people might experience hypervigilance, so they are kind of always looking where the threat might come from, or hypovigilance, which is a very low arousal state. Trauma also alters our ways of thinking and cognitive. It creates cognitive problems. So, for example, it's very difficult to concentrate, and that's very understandable, since if your mind and your body is always concerned by surviving, then you cannot really focus on studying, for example. And another probably very known symptom of PTSD is the intrusive symptoms, such as flashbacks or nightmares, when the trauma comes back and the person basically relives it and feels like it's happening in the here and now. And these are triggered by any reminders of this traumatic event. And these reminders might be conscious reminders that we know of, that the situation is similar, but they might be some very unconscious ones that we don't even recognize. The person doesn't even recognize that they are being triggered. But still they are taken back to this trauma time. And lastly, it also has these avoidance symptoms, that the person might become very isolated because they want to avoid all the triggers. So in order not to be triggered, they are very isolated. Sorry, it was probably longer than...
I think we have a general understanding, or a common understanding now, about what trauma is. So before we go into how people reach out or not reach out for help, can you mention a couple, and I'm not saying like an exhausting list of therapies for PTSD, but a couple that you yourself practice at the trauma center?
Okay, so there are some evidence-based practices for PTSD. One of them is cognitive behavioral therapy, trauma-focused cognitive behavioral therapy. There is also prolonged exposure therapy. There is also EMDR. I'm an EMDR therapist, which is eye movement desensitization and reprocessing. If there's time, I'll talk about it in more detail, what that is. And there are also other practices, more body-based, such as somatic experiencing, and maybe MDMA.
And maybe MDMA, yes. Thank you. Now I will turn to Olivia, because you also deal with depression, anxiety, which are also symptoms of, or can be symptoms of PTSD. In your own practice or research, what did you find if people experience these symptoms, why don't they reach out?
It can be difficult to reach out because there's still, sometimes people feel ashamed of what they're experiencing. Sometimes it can be difficult to put into words what you're going through. And also this stigma that, that is still there, and it can make it difficult for somebody to come forward with what has happened. Trauma is a complex issue, and many things can feed into that. So it's certainly, it can be a long, winding road to get to a place of where you'd like to get to.
Thank you. So there are a number of different ways to deal with trauma, but there is certainly the stigma of reaching out for a professional help to deal with it, because sometimes patients don't recognize that this is available. And there are some medications that are also stigmatized by society or policy, and we're going to be talking about this as well, which is MDMA-assisted psychotherapy, which has been a very hot topic recently, especially in the UK for the past 5 years, I would say. So before we go into the controversies, I would just like to debunk some myths around it. So, Levi, can you talk a little bit about what MDMA-assisted psychotherapy is?
Yes. Very briefly, it's very important that how people think about drugs in general, and in special some certain drugs that can be used medically. These are not two very different areas, because there's a lot of overlap between the illegal drugs, which are called narcotics or whatever, and those substances that had been used in pharmacotherapy, and lots of illegal drugs these days are pharmacotherapeutic agents that had been illegalized at some point, like some 10 or 20, 30 years ago. But basically, the ban of drugs is a relatively new phenomenon. So these illegal drugs had been banned in the 1960s, 1970s, and before that they could have been used in therapy. And the history of MDMA is also very interesting. Of course, as a relatively new drug, kind of rediscovered in the 70s, and had been used actually in therapy throughout the late 70s and early 80s. So this is not something that now it will be the first time that people try MDMA therapy, because lots of therapists had been working with MDMA, and at some point when MDMA got banned in the US, primarily in 1985 and 86, and from that point on, therapists couldn't use MDMA. And there are some data back from that time that it had been used like some tens of kilos of MDMA each year for therapeutic purposes. And it was not illegal therapy, because MDMA was not illegal until I think 1985, when it was emergency scheduled in the US. So this MDMA therapy is not the type of self-therapy on the dance floor, which had been cheered here in the introduction, but it's kind of a special form of therapy. It's a combination of pharmacotherapy, which is the classical thing that you go to a psychiatrist with a mental problem, the psychiatrist prescribes you some kind of pharmaceutical agent, you go to the pharmacy, get the substance, go home and take the pills, and then go back to the psychiatrist in a month or whatever time, 6 weeks, and just calibrate the dose. So, and the other approach is kind of the talk therapy, when you go to a psychotherapist, and then without any kind of pharmaceuticals, you just talk about whatever the therapist thinks that it's important, starting with your early childhood and experiences, or if it's a trauma therapy, then some kind of talking about the trauma. But this is where the clinical psychologist skills are very important, that how to approach this trauma without, for example, re-traumatizing the patient or the client. So this MDMA-assisted psychotherapy is a combination of these two. So there is a substance, a pharmaceutical substance, legally, MDMA, and there is a psychotherapical approach with these whatever kind of methods that the therapist is trained and experienced in, like Júlia said, like EMDR or whatever is the specialization of that particular therapist. So what is expected in the next few years is that MDMA will be fully officially approved drug, which can be used under very, very strictly controlled circumstances for psychedelic-assisted therapy, MDMA-assisted therapy. So at this point, all the clinical trials are in the very, very final stage. So there had been all the basic research done, all trials in healthy people had been done, trials with patient populations had been done, and now there's multi-site research going on with actually, I guess, like thousands of patients who are getting MDMA at this very moment. And after the results had been all wrapped up, then there will be a permission from the US FDA and the European Medical Agency, and MDMA will be like a drug like any other drugs that can be used fully legally for therapeutic purposes.
Thank you. Now we a little bit more understand what is the stigma or policy behind it, or how it was accessible at one point and it's not accessible now. There was in the 80s in America a war against drugs, and this is basically one of the influences that it had. What I would ask before we go on is that why is this so special? Why do we want to go back to this particular therapy if there are other therapies available and other pharmaceuticals available? So basically, why is this something that we should approach? What happens to the brain that makes it effective?
Well, in pharmacotherapy, there are kind of different eras, and the current era is the era of the SSRIs. So it's the selective serotonin reuptake inhibitors, and these are the drugs that are prescribed when someone has depression, and it's not exactly based on research. It's kind of discovered by accident. So I guess the story is something like there was a patient population with like tuberculosis or something, and they got this SSRI for treatment, and somehow the treatment personnel noticed that these patients are so happy. So basically it acted as an antidepressant, and they found out that this is a SSRI mechanism, so there's something to do with depression and the serotonin level. And this is actually just a model. It doesn't work for everyone, and now it had been researched, and they found out that the placebo effect, which means that if you get a pill and then you believe that the pill will heal you, then there is a 20 to 40% chance that you will be healed. And it's nothing to do with the pill's ingredients. It can be just a piece of sugar. And if you use an antidepressant like an SSRI, then this chance to be healed is like around 40 to 60%. So it means that with placebo, 20 to 40, and with SSRI it's 40 to 60. So it means that it's not actually the drug, the pharmaceutical agent, the neuropharmacological mechanism which does the healing or all the healing, but there's a huge effect of the placebo effect, which is a psychological effect and kind of like a self-healing effect. And on the other hand, the rest 60 to 60% or 40 to 60% is not getting healed even with antidepressants. And I think there's it can be stated that there's a mental health crisis going on in the world now in the 2020s, especially because of all the situations, all the coronavirus, isolation and separation for people, and all the measures, and also the war situation, inflation situation, whatever things are in the current history. And we need novel approaches, and we need new treatments, because the old treatments are working only partially. And this phenomenon now, which is going on, is called the psychedelic renaissance. So it means that after some 40 years of the psychedelics being banned for political reasons, it had been like an area of taboo. So researchers couldn't do research with psychedelics, and no one knows about psychedelics any kind of knowledge with the modern approaches and modern equipment. Like, for example, neuroimaging is like a technically very advanced research area, and because of this ban of something like 40 years, it's only in the last, I guess, maybe 10 years, but even less than 10 years, when it had been possible to study people who or patients, or actually not even patients, just subjects, by giving them psychedelics and then just measuring that what happens in their brain with methods like fMRI or positron emission tomography or these new neuroimaging methods. So we don't know about these substances, but we have some good experience by healing with these substances from the 60s and 70s and early 80s. So this is why the Renaissance is important, because we can access these drugs and we can gain knowledge about it, and then we can find new directions for this mental health crisis.
Yes, go ahead.
Hello? Yeah. Something that of course I didn't try because I haven't done MDMA assisted therapy, but something that I read about it and made it very interesting to me is that why it helps is that in all kind of trauma therapy, our main goal is safety. The person lost their sense of safety, and we would like them to regain it. And when this safety is there, part of that safety is that they can regulate their states. So they are not in this hyper-vigilant fight or flight or freeze, hypo-vigilant freeze reaction. They are somewhere in between, in a state where we can talk, where we can feel emotions, where we can reflect. That's a normal state for us. And for many people with PTSD, this is extremely difficult, and we do a lot of stabilization with them for them to feel safe, breathing exercises, relaxation, body-based exercises, etc. But still, it doesn't always work. And what I've heard that with MDMA, this safety can be more established. There is more self-compassion, and which means there is less shame and guilt, which is also very much connected to PTSD many times. And so with these sessions, it creates this window of tolerance, basically. You can work with the traumatic memory a little better as a therapist.
Thank you. Yeah.
One thing that I wanted to mention is in the UK at King's College, the Institute of Psychiatry, they've been researching this, and they're working on laying out the groundwork for making this available, in the coming years, and making it accessible for people who have experienced trauma and severe PTSD.
This is a good segue, what Olivia just pulled in, that there are many different therapies available, but this is something that has yet to be green-lighted by many countries. So before we go on discussing whether this is going to be a possibility, what do you guys think? Because Levi mentioned mental health crisis as something that's very current, and I think most of us felt or experienced in our surroundings someone who has difficulty coping with the anxieties of current events. What are some things that are publicly available, and what do you think, are they effective? Because as far as I know, mental health resources are also extremely expensive for most people, and it's very privileged to access them. So what do you think, Olivia, from the UK and Hungary? It's a very different economical situation, I would say, but do you think that the available resources are enough, or what are some of the limitations?
There are challenges to getting the treatment and services that you need sometimes. And, in the UK, for example, the waiting lists for getting the therapy that you need, for getting counseling sessions, so long waiting lists. And so, that's certainly a challenge that needs to be looked into more and overcome. And at the moment, I'm looking at, one of the things that I'm looking at is mental health in the construction industry, because construction professionals, which is a male-dominated industry, it's got one of the highest suicide rates. And in fact, if you're looking at the suicide rate in men in construction, it's 3 times higher than that of the average male population in the UK. And they're dealing with, people in this industry are dealing with significant stresses. Accidents are happening at work, people losing their lives sometimes on the job because of, it could be a health and safety issue, or it could be suicide, which has been triggered because of an underlying mental health condition, the high stress levels, high levels of anxiety as well. And one of the challenges is people sometimes not being able to access the help they need when they need it in the moment. Of course, there have been significant improvements, in the last while, but more still needs to be done. And, when you're at work and one of your colleagues has taken their own lives, that can be traumatic. Not only for the person close to that individual, but for the whole team, for the organization, for the community that they are part of. So we also need greater awareness, I do believe, when it comes to these issues, and showing people that when something like this happens, the trauma has a spillover effect. So that's important. And what kind of help is there available? So there's cognitive behavioral therapy, as has already been mentioned, talk therapy, discussing with a trained professional about what you're going through. And as you're doing that and potentially reliving the difficult experience, reliving the trauma, then the counselor can help to pinpoint where there may be assumptions or beliefs that are holding you back, and where you may need to revise, and you work together, to revise those beliefs and assumptions that are holding you back. So all of these things are available, but I do believe that we need to make it more accessible, and also to do something about those long waiting lists. And I just want to give a specific example to the people listening to this. So, I talked earlier in my presentation about this focus on worst case scenarios. That could be something that could be pinpointed during the therapy. So maybe something has happened to you in the past, an accident, a car accident, let's say, and now you are feeling responsible for what's happened. You are taking all of the blame on yourself, and let's say it wasn't your fault at all, but for some reason you are taking on this guilt, and this is traumatic. And in a counseling session, you might be talking about this and going over the details, and perhaps discussing the validity of your assumptions, that it is your fault as you may perceive it, and discussing the evidence for and against that. What is the evidence for that? What is the evidence against that? And this can help you to develop a more balanced view of the situation, and to realize that maybe, actually it wasn't your fault, or maybe, and the importance of letting go of that guilt and self-blame, because that is key in moving forward from the trauma, one of the key steps.
Yes, Levi, go ahead.
Check. It was very relevant that Olivia mentioned this suicide, the topic of suicide, because one of the driving forces behind the development of MDMA was the trauma of war veterans in the US, from where this development of MDMA to a drug has begun in the late 1980s, because maybe you know that those veterans, US veterans, who had been in wars like in Iraq and Afghanistan, there are more US veterans committed suicide than how many veterans or how many soldiers had been killed in those countries, in Iraq and Afghanistan. So this is a really huge problem for the United States, that the veterans come back from the wars and they just can't live with this trauma and they commit suicide. So I think this was one of the most important things, that after the mental health system in the US kind of realized that there is no way dealing with so many thousands of traumatized people from whom a really big portion will commit suicide, then this was behind that the MDMA got a green light in research. It's not a product of the big pharma, because it's an old molecule, it can't be patented, so no big pharmaceutical company would take this pharmaceutical development for MDMA, so it got some very special permissions, like an orphan drug, and this kind of very special way to be developed into a drug. And it's the other indication or type of trauma is sexual trauma. It's sexual abuse and like really hard cases, like treatment-resistant cases of sexual trauma, were one of the patient groups who had been involved in this in the research of MDMA, the success of MDMA therapy, and it had been found out that it's really efficient. And one thing that must be mentioned is why MDMA is special. There is this effect that had been mentioned here, that in working with people or patients, basically the patient is in a baseline state, and the MDMA therapy is kind of based on altered state of consciousness therapy, which means that the patient is put to an altered state of consciousness, and the therapeutical process is carried out while the patient is in the altered state of consciousness. And with MDMA, the effect of MDMA is that a really great amount of trust is manifested, and it's not only like euphoria, like good feelings of the person about himself or herself, but also that there's a really great trust towards all people around. This has something to do with oxytocin, this hormone that binds people, binds like the newborn infants and their mother. So it's a bonding molecule, and in a therapeutic situation, MDMA causes this effect that the person is really opening up to the therapist and can talk about his or her trauma without getting re-traumatized again. And it was also a very good example if someone has caused an accident, and in an MDMA acute MDMA effect situation, the person's guilt can be really diminished by MDMA, and can open up and can understand that other people's point of view, and can even forgive to himself or herself. So it's a really different psychological situation for that, say, 4 hours of acute therapy. So this is why this is a special molecule, and it needs a very special approach in treatment from the therapist side.
I would just add one thing to this, that many times people who survive something traumatic and feel they know that it wasn't their fault, for example, victims of sexual assault, so cognitively they understand what happened and what they couldn't, resist, for example, but they don't feel that way. Many times in my practice, I experience this, that when we just talk about what happened, the person explains it in a very logical manner. But when we get to these layers of emotion, it turns out that they're still blaming themselves. They're still blaming their outfit. They're still blaming their behavior, whatever. And even though they know they shouldn't. So this knowing and feeling are very different layers. And I believe in this altered state of consciousness, there is less logic and more of the emotion. that can come out, right? So it's not about beliefs, it's
it's really a lot about emotions. It's more like that. It's a state when the person feels that just remembering the traumatic event will not traumatize him or her again. And usually there's a problem of recalling the traumatic event, because it's a self-defending system which blocks the access to the memories. So many times there are some flashes of the bad situation or the trauma situation, but it's nearly impossible to get the patient to talk about the situation, because reliving the situation is emotionally and in bodily effects could be as traumatizing as the original effect, original situation or event. So this is why also not with the physical trauma or sexual trauma, there is a possibility when, like, to use MDMA in a couples therapy, because if couples take MDMA together, then there is this feeling that my partner doesn't want to hurt me, and I don't want to hurt my partner. And there is this feeling that since I feel that I don't want to hurt my partner, I can tell anything to my partner, and my partner can tell me anything, because I won't be hurt. So MDMA could do this binding and this trust level, and with a therapist it's the same thing, that I can tell anything to my therapist, because it won't be any kind of awkward situation if I tell my deepest feelings or whatever. So this is what the basis of the therapy.
What I would like to come back to for a minute is something that we approached already, that resources available are limited. In the UK, probably differently, but definitely waiting list. This is something that's very much happening in Hungary. Can you tell us how long should a patient wait to access public health or public financed therapies?
Well, if you think about outpatient therapy, then the waiting lists are very short, because I don't think they really exist. Sorry. Of course, there are instances where they do, like in outpatient psychiatric clinics. There are therapists and there is a waiting list, but that's so rarely available, really, to people. And throughout the country, it's like if you live in Budapest, then maybe there are resources, but throughout the whole country, there aren't really. Inpatient psychiatric institutions do have therapeutic wards, but that's another. I think that's another more treatment, and they are not really specialized in trauma. So it really depends on the therapists themselves who work at these places, if they are aware of trauma, if they are trauma informed, if they think with these trauma filters, because many times what I experience is that even for trained clinicians, this way of thinking, of not looking at what's wrong with the person, but looking at what happened to them, is new, because I wasn't trained that way. We weren't trained that way, and we really had to look for this information in order to get it. And of course now things changed. There are more therapists being trained in this field, but I think not enough. So yeah.
Actually, this is what I wanted to ask next about training, but go ahead.
Just one more thing, because I am the clinical director of Trauma Center, and we do have a waiting list also, so maybe I should point that out too. We are a non-profit organization, and so we have for-profit activities in order to finance our non-profit activities. The for-profit ones are awareness raising, trainings, psychological first aid, for example, for companies, and so more but we are very small. So organizations like us do provide therapy for survivors, for more specific populations, for sexual abuse survivors. There are NGOs, etc. So I'm not saying that there isn't any, but that's not public.
Yes, so that's the thing, that NGOs are probably few and far between in most of Europe and also in the US, as far as I know. And specific training is something that's also needed for different experiences with trauma, PTSD. What do you think, if we take out pharmaceuticals for a minute and just focusing on all the mental health providers, both in coaching, both psychotherapists, this type of special view that you mentioned, that not looking at a patient, what is the problem with them, but what happened with them and how could they live with that event. How much is it part of current training, and is it enough? This is also a question for Olivia. Probably in the UK it's a little bit different, but what is your experience? How many therapists, or how wide is this sort of viewpoint from therapists or mental health professionals?
I think this topic is becoming more and more popular. I think we can see, we are talking about it in SZIGET Festival, right? So there is more and more interest, and I think that's a good thing. And because of that, more and more therapists are being trained in these practices. That's what I experienced in Hungarian. In my Hungarian experience is that when we did trainings for psychology students or people who got their masters but they didn't have their further education, they said that they heard really, it was new to them what we were talking about.
And also the other thing is, I feel like more research needs to not only be done on this, but also to be disseminated to the public, because trauma can happen in a wide variety of circumstances, and it can range from experiencing an illness, being in an accident, but also experiencing a devastating divorce or a breakup, difficult financial situations, so in a wide variety of circumstances. And awareness levels about this needs to increase, and this is where public health comes in and public health campaigns. And the movement that we've had with mental health and increasing people's knowledge about mental health and well-being, I believe that, when it comes to trauma specifically, more needs to be done on that as well.
It would be interesting to know that, I would ask the audience that how many people are here who are psychologists, maybe, or psychology students, and how many people have heard about MDMA assisted therapy in general? And I will ask the psychologists and the psychology students if MDMA assisted therapy was mentioned during their education. Kind of. It's a kind of thing. So I guess this is the thing, that if anyone wants to be a professional as a psychologist or other kind of therapist, because MDMA therapy is being done not only by psychologists but by other mental health professionals, it will be possible. But this could be realized really within some years. And therapist training is not the future; it's only already today. There are several organizations who are training MDMA therapists at the moment, even though MDMA therapy is not, MDMA assisted therapy is not possible at the moment. But the need is established to be, even though at the moment there are more than 1,000 MDMA assisted therapists had been trained, but the need is for about 20,000 MDMA therapists. It's an estimation in the US, and The next phase will be psilocybin-assisted therapy, which is a little bit different, and the need estimation is for 100,000 psilocybin therapists in the future. So if you are into the mental health field, then this will be something that you will definitely hear about in maybe 5 to 10 to 15 years.
Now, something added to that, or a kind of a follow-up question, you mentioned that there is this immense need for therapists who are trained in this specifically. What do you need to do? What sort of what is something that is absolutely essential in this type of training, and how long does it last? Because if there is this need and education for mental health professionals doesn't cover it, this is going to be an additional training that you need to do. And I guess there is going to be a gap between the year when the need is there and there are no therapists who are actually trained in this.
Even though I'm not working with clients because I'm not a psychologist, I just have a PhD in psychology. But I think one of the most important things to learn for a therapist is how to work with a client or a patient in an altered state of consciousness. Because apart from hypnotherapy, the treatment process is being carried out when the patient is in the everyday baseline state of consciousness. I think one important thing is for the therapist is to realize that what is the effect of MDMA. Now it's also very, very interesting to know that I guess maybe some persons in the audience have seen other people being under the effect of MDMA. So how many of you saw people under the effect of MDMA? This is the dance floor question. So I guess you have some kind of a picture that how MDMA works on people. I won't be asking if you have some first-hand experience or not, but it would be a nice play that if you could just please act out how MDMA works for the person sits next to you for the. Yes, I think there's some people have some idea about the treatment process, and those people who have this experience can really know that in that state of mind, there's a lot of things that can be solved between two human beings. So this is one thing that the therapist should be aware of, that how people act while on MDMA, and it's a really strange thing that how can it be part of an education of therapists to bring people there who are under the effect of MDMA for the therapist to be trained that how to relate with the people who are under the effect of MDMA. So these are open questions for the therapist training in the future.
Self-experience is very important in every modality, in every type of training. So when you study EMDR, you need to experience the EMDR yourself. So yes. Absolutely.
And actually this had been the golden standard in psychedelic research in the 50s and 60s, that the researchers tried out the psychedelic on themselves first before giving it to the patients. So even in Hungary, there are the old issues of the medical journal when there were some psychiatrists doing research on patients, or actually treating patients with LSD, and in the journal publication, it has been written down that first we tried the LSD on ourselves and then we treated the patients with the LSD. So it was a protocol. So it's kind of like, I don't know what would happen if psychiatrists today had or should try the SSRIs or whatever kind of antidepressants on themselves before prescribing to the patients. It is not happening because it's not part of the protocol now. But for psychedelics, this might be the protocol.
Actually, this is what I wanted to ask, and slowly we need to wrap up our conversation, and then the floor is yours, and you can ask our panelists questions. But this protocol seems a little bit risky, if I'm being honest, and this is where I wanted to kind of go with the next question. We have been talking about the positive effects of MDMA and all that it can open up, and that we need to research it. Basically every single drug, even legal ones, have negative effects. It is something that brings up an altered state, what are the risks that we need to be aware of, and what is something that even if this becomes legal practice, there needs to be within the policy of administering these drugs?
Yeah, so it's important to realize that these were clinical trials which established the efficiency of MDMA, and now it goes out to the therapeutic settings. And in a clinical trial, it's a very, very controlled environment. There's a 100-page protocol of how to do exactly the therapy, and including that the MDMA should be like laboratory grade, and the dosage is really, really calibrated, and the patients are really, really pre-screened for any kind of like heart diseases or liver conditions or whatever. So it's a very, very strict protocol in research, and some negative effects are not likely in this protocol, but outside in the therapy, it is more likely to happen. And one of the risks is the therapist himself or herself. So in the US, it's been known that when there is an abuse of a patient, then it's, I think it's the most frequent is when a psychiatrist abuses his or her patient. So this is one thing that should be addressed, that it needs a very, very regulated training and very, very strict protocols and control of the psychiatrist or psychotherapist who is treating the patients, in order to prevent any kind of abuse from the therapist side. And from the other side, it's also because this is why MDMA therapy is not for lay persons. It's not like that, hey, my friend has some problems and I give him or her MDMA and then I can give a therapy to my friend. It's not like that. It needs trained professional nurse specialists who can handle patient work. And this is what the training is for psychologists for many years.
And the other thing that I want to mention is, when it comes to talking about such substances, we also need to be mindful of, potential for addiction and abuse, and just doing more studies on this and really looking into these aspects, especially if it's going to be something that's going to be rolled out more widely.
So to wrap up our discussion and to hand it over to the audience, since we've been talking about needs of public mental health access and maybe widening policies or making sure that a lot more people have access to different sort of therapies, I would like to ask each one of you to form just one wish that you have for the future, that within your field of practice would be possible in the next, let's say, 5 to 10 years, that you would like to see change or you would like to see advocated.
Okay. Well, I would like to see a country, and I think a world, maybe more aware of these things, of trauma and trauma-informed practices. One of the biggest wishes for me is to use the knowledge we know about trauma not only in therapeutic practices but also in other types of care. This is what our podcast is about as well. So I think others will add to the wish list, but this would be mine.
Thank you.
For me, number one, tackling long wait lists when it comes to getting the mental health care that people need, and the services that people need. And also, when it comes to the different therapies, conducting thorough, rigorous research to find out not only about the benefits, but also the risks. Both are equally important, and people, having access to this information. And for me, those two items are important.
So I should tell a wish? as if seeing a shooting star.
Yeah, yeah.
I actually saw a couple of shooting stars like, the other day, because this is August. I wish to see that one signature on this legislation that is approving MDMA therapy for Hungary, and I don't know whose signature it is. Either it's the Prime Minister or it's not the Minister of Health, because we don't have a Ministry of Health in Hungary. But anyway, I wish that someone would realize that how important thing this is and how big opportunities for people who struggle with mental health. And I wish a kind of easy and not complicated way to legalize MDMA-assisted therapy.
And ultimately, just one quick thing, you know, in the UK, for example, when we're looking at rates of anxiety or depression, 1 in 6 people are affected. So ultimately, my wish is for mental health overall to improve for people, to see a lowering when it comes to anxiety, depression, stress, trauma. Of course, you know, that's an idealized an ideal thing, but if we don't have those goals in mind, then we can't work towards them.
I very much agree, and thank all of you for sharing your thoughts about this particular topic. And now I would like to invite the audience for questions. Yes, I already see. Yeah, okay.
Thank you. There we go. Maybe a little bit of a speculative question, this one, but you already talked about how these sorts of substances were already researched before, then they got illegalized, now they're legalized again. What does the future hold? Is MDMA slowly but surely walking the track of marijuana, that it would eventually also be legalized for, well, free use by the public? Is MDMA just the first of these substances that we are researching, and are other psychedelics and even other, which are now illegal drugs, soon to follow? What are your thoughts on that?
Actually, this the division between legal and illegal drugs is not so deep as people would think, because a lot of illegal drugs had started as legal drugs, and a lot of illegal drugs are in clinical use even today. Like I don't know, amphetamine is an example. It is for a treatment for different things, and GHB and I guess cocaine is even used in medical procedures, and actually a lot of them. And one which is a special one is ketamine. Ketamine had been used not only for animals in veterinary science, but also for human anesthesia. And ketamine is very special in the sense that this had been discovered just a few years ago, that ketamine is not just like an anesthetic, but it's very efficient for treatment-resistant depression. It's not a one-dose therapy, but it's more like a few doses, like 2 doses per week for a few weeks, and it's really efficient in combating treatment-resistant depression. So what is possible today is to open up ketamine clinics. There had been a lot of new ketamine clinics throughout the world, because it's a legal substance, and under controlled circumstances it's possible to use ketamine. So the future will be that those clinics that are treating patients with ketamine, they will be the MDMA clinics as well in a few years. Later they will be the psilocybin clinics, and sometimes later maybe the LSD-assisted therapy clinics. So these are the steps for the future, and medical marijuana or medicannabis is a kind of related but kind of separate topic. But I guess because this is a very international festival, that I would say that even in most of the countries that you come from, medical cannabis is legal. And I can do a query. In how many people's countries medical cannabis is legal or accessible for patients? So there are hands in the air, clearly. So this is also not tomorrow, but it's today already. And this will be slowly the procedure with all substance-assisted therapies which turn out to be efficient or more efficient than the therapies of these today.
I would like to know how long-lasting is the effect of like MDMA therapy, and if there are any studies which compared psychedelics therapy to, for example, CBT therapy, like how different is the effect of to these options?
There are different kind of protocols for therapies. Generally, psychedelics-assisted therapies are could be even one or two occasion therapies. Like the most prominent is ibogaine, which is used for opiate addiction, reducing craving, because ibogaine therapy is just maybe like 2 times therapy, and it stops craving for opiates so efficiently that it never should be used after this therapy. And all these substance therapies should be supported by psychotherapies, and in the research they do the follow-ups for the patients or subjects who participated in the clinical trials. They are usually like a 12-month follow-up is part of the protocol, and so the efficiency that we know is from the 12-month follow-up compared with the follow-up after CBT or whatever other non-substance therapies. So we can compare this on at least on a 1 year time interval.
Can you? Is this effect? You said like it lasts for 12 months. Is it when you combine this MDMA therapy with psychotherapy or just separately?
Sorry, maybe I wasn't emphasizing that this is not like only a substance therapy. This is always a substance-assisted psychotherapy. So there is an ongoing psychotherapeutical process with a chosen therapist or practitioner, and a part of this therapy is usually 2 sessions with MDMA. So it could be like they also use other substances like psilocybin for smoking cessation, for tobacco, and it's also like a really, really long therapeutic session, maybe many months, with the methods that the therapist is trained in, and in 2 sessions only there is a substance-assisted part. So it's not that you can start with the substance. It's always that you do a therapeutical process, and if your therapist thinks that this could be good for you, and if your pre-screening says that okay, it should be okay with you, then they give. And the MDMA protocol is, I think, maybe 2 sessions. It depends. There's no like such. In one country there will be one protocol, but in another country it could be different. But based on the clinical trials, it's 2 sessions is the standard or protocol for MDMA. 2 sessions is good enough for psilocybin. For ketamine, it's more tricky. It's maybe twice per week for 3 weeks, or it needs a little bit more. For ibogaine, it's 1 or 2, or actually, yeah, 1 or 2. It could be even 1 session. And LSD is a little bit different because we have only experience or knowledge from the 70s or 60s, 70s, and there were different protocols. So with LSD, there is not so much research going on yet. So for LSD, I don't know if it will be a part of like a longer or many therapies, or maybe just a one-time therapy. It's not yet kind of developed.
Sorry. So as far as I understand, it will be the clinician's judgment, basically, for someone who maybe resists other methods, or that they feel that there is no development. Then this could be a second line, or even probably not first line intervention, which the therapist can try. And then they experience this together, and it's guided through by the therapist.
It's definitely for hardcore cases. All psychedelic therapies are for hardcore cases, treatment resistant cases, and in pharmacotherapeutical point of view, it's after trying out maybe 3 different substances on the patient and there is no improvement, then they will refer to a psychedelic assisted therapist. So this is not any kind of like I say that, oh, I have such a trauma, where is the MDMA? So it's not like that.
Thank all of you for all this very important information. Unfortunately, we need to wrap up, but thank you for the questions. I think these were also important issues to cover. And please give a big applause to our fantastic panelists. And thank you for being with us today.